This is exactly how you can get tricuspid valve endocarditis. It's not the only way, but it's one of the most frequent causes for endocarditis of the tricuspid valve. Why? Well, you can see for yourself, he's not really injecting the substance under sterile conditions. But that's not the only reason, as you will find out in this chapter. As a matter of fact, you can even use the so-called no-need echo formula, as I call it. If you have a patient who comes to referral for echo and he has pulmonary abscess, he's an IV drug abuser, and you even hear a heart murmur, you don't really even have to perform echocardiography because the likelihood is very high that he has tricuspid endocarditis. Of course, you'll perform echocardiography in these patients, but keep in mind that approximately 10% of patients who have endocarditis have right-sided endocarditis. There are several reasons why IV drug addicts get right-sided endocarditis in the first place. First, there's a direct toxic effect of the drug itself on the endothelium. And remember, that is usually the beginning of endocarditis, endothelial damage. Second, such patients are usually immune compromised, for example, HIV patients. And finally, usually there is some form of contamination through the needle and through bad hygienic conditions. Aside from intravenous drug abuse, there are also other predisposing factors for right-sided endocarditis, such as immune compromised patients in general, indwelling catheters, especially such patients who have prolonged stays on the intensive care unit, and finally, pacemakers. We'll talk in more length about pacemakers later. Here are some facts about tricuspid valve endocarditis. The most common organism is Staph aureus, which accounts for approximately 60 to 80% of cases, followed by Pseudomonas. Right heart failure can occur, however, it's fairly infrequent, and it is usually either a consequence of tricuspid regurgitation or pulmonary hypertension, which is caused by recurrent embolism from the vegetations. The prognosis of tricuspid valve endocarditis is actually relatively good, somewhere in the range of 10%, so much better than for native valve endocarditis of, for example, the aortic or mitral valve. It is, however, poor if we have fungal infection, and one of the major problems is that we have a very high reoccurrence rate, simply because drug addicts simply don't stop their drug abuse. Just for review purposes, here are the views where you can image the tricuspid valve best. First of all, the four-chamber view, but even better than the four-chamber view is the angulated or tilted or atypical four-chamber view, where you often have a better visualization of the tricuspid valve. Don't forget about the peristernal right axis view, where you can nicely see the tricuspid valve as well, and then also the peristernal short axis at the base. In general, however, don't forget to use atypical views, for example, to also use the inflow-outflow view and to rotate around the tricuspid valve from the apical approach, for example. What are the potential complications of tricuspid valve endocarditis? Well, not much different than in other forms of endocarditis. Valve destruction, infect expansion, septic pulmonary embolism, and lung abscess. So it's often worthwhile to use the transducer also to look at the pleura and to see if some form of infection or effusion is present there. Here are some examples. Short axis view, beautiful view of the tricuspid valve, which is completely destructed, and we have mobile masses on the tricuspid valve. Here again, a short axis view, however, this time from a transesophageal approach. We see very large vegetation here on the tricuspid valve, maybe even here on the aortic valve. Here we have a four-chamber view. The first thing we see is a large mass which moves between the right ventricle and the right atrium. So it's very difficult to say if this is all vegetation or if this is not also partially at least a flail leaflet of the tricuspid valve. Note that there's also pericardial effusion, an additional finding we do see occasionally in patients who have tricuspid valve endocarditis. Here's another fairly large vegetation of the tricuspid valve, again very mobile mass, which was found in an only 16-year-old drug addict. Keep in mind that tricuspid valve vegetations can get fairly large actually. Here's another example, a patient who has endocarditis, which is not fresh anymore. We see that the vegetation is a bit more dense, So this is approximately 3 to 4 weeks old. But again, destruction of the tricuspid valve. And here a case of a patient with endocarditis who has severe, or at least moderate to severe, tricuspid regurgitation, and also a small pericardial effusion. And these image clips are actually the only image clips I was able to find in our database of a patient who has pulmonic valve endocarditis. Sometimes we do see it in combination with tricuspid valve endocarditis, but isolated pulmonic valve endocarditis is extremely rare. You see the vegetation here in a short axis view, also a thickened pulmonic valve, and here we see the vegetation in the TE in the short axis view as well. One thing to remember is that if you have endocarditis of the tricuspid valve, don't stop there, but also look at the other valves, because we do see multivalvular endocarditis. For example, here, a patient who has a mobile mass, a vegetation on the aortic valve, but also on the tricuspid valve. So this concludes the chapter on right heart endocarditis, on endocarditis of the tricuspid valve. Remember again, if you have a drug addict, if he has fever and septic emboli and even a systolic murmur, then he most likely has tricuspid valve endocarditis. But now we'll have to move on to another devastating form of endocarditis, prosthetic valve endocarditis.